So we're going to go straight in. I'm going to go for the first question. Which of the following is true? So bias is a random error due to sampling variation that reduces as sample size increases. Bias is calculated by the fraction of the true value and the expected value difference and does not reduce as sample size increases. Bias is quantified by the difference between the true value, expected value, and does not reduce as sample size increases. Or bias is calculated by the fraction of the true value and the expected value difference and does reduce as sample size increases. So if you guys can put your little A, B, C, or D in the chat, I would greatly appreciate that. I'll give you about 30 seconds. Ooh, we have some people typing. Very thrilling. Okay, yes, you are correct, Andrew. It is indeed C. So C is the answer. The first option A actually discusses chance. So chance is a random error. A random error is something which is kind of inevitable. It's going to happen no matter what. And it does reduce as you increase your sample size. So the bigger your population, the less likely you are to have a result that is due to chance or good luck, essentially. Bias, however, is more systematic. So bias is something to do with the process of you conducting your study. And it's a systematic error. So biases include like interviewer bias, where the interviewer has a lot of knowledge in a specific area, so ends up sort of manipulating the results in a way of what a patient might be saying, or it could be recall bias. The patient forgets something, over or underestimates what they do. For example, cigarette smoking, they may not want to admit that they smoke 50 a day and may say that, oh, it's actually 20 a day, for example. So bias is generally systematic, and no matter how many times you increase the population size, you're always going to have bias. Okay, question 2. So this is a math question. You will get a lot of math questions in your MCQs. So this one is to calculate the prevalence. So in a single center study of 150 people, 35 tested positive for influenza. What would be the prevalence per 100,000 people? I'll give you guys about a minute, but it should be hopefully okay. See some typing. A, very good, very, very good. Indeed, it is A. So the way you would go about that is, so prevalence is how many individuals have this specific condition at this exact time period. So it gives you a snapshot of what's going on at the time of you collecting the data. So what you want to do, you want to divide the number of people who tested positive over the total number of people. And then you want to multiply that by 100,000. So by doing that math, you will get 23,333 per 100,000 people. A lot of people tend to forget to put it in the way that the question wants it. So the question doesn't want just the proportion or the ratio. The question wants it per 100,000 people. And that's where a lot of individuals might end up losing marks, is where they forget to put it in the same units as the question. So do bear that in mind as well. Is everyone okay so far? Oh, do we have a question? Is this session being recorded? I am not sure. Is it being recorded? I think it is. I see a little green dot or red dot. Yeah, it is being recorded. Okay. Lovely. So the next question. Using the following table, calculate and interpret the odds ratio for getting sunburns in the holiday abroad group versus the staycation group. So I'll give you guys about 2 minutes to do this. Oh, we have a new joiner. Thank you for joining. While you guys do this math, I'm going to quickly grab my coffee. I'll be right back. You will get odds ratios, a lot of math questions in your exam, and generally they are MCQ. I think I have seen 1 or 2 as an SAQ. So, and SAQ public health questions are generally like 10 marks out of 100, or like 120. So that's quite a significant percentage, which is why I wanted to cover these topics. Also, if you're confused, at the end of the session, I'll email Elena, basically like I did for the revision session, a little booklet which has the answers and explains it in detail. So you don't have to worry too much about taking notes, but rather just try to understand the information. But has anyone calculated an odds ratio for me? It's okay if not. Ooh, a lot of people typing. Love it. Let's check the math on this one. It's all good. It can get a little bit funky. Okay, no worries. So whenever you're given a table, such as the one here, the main thing you want to do is quickly just add up all of your totals. So you want to complete your table before you do any of the math. Complete your table. So you want to get your totals vertically and horizontally, and that will just allow you to understand the data more, get familiar with it, and make sure you check all of the headings so you know that, okay, this is the diseased group, this is the non-diseased group, and this is group A and this is group B, because sometimes they will throw a curveball and not do it in your traditional A, B, C, D kind of organization, if that's the right word. So it's really important that you check the headings and add up all your totals because it will come in handy. So to do the odds ratio, so 44 is correct, Liv, very well done. You might be wondering, why does it say 46 here? So I'll tell you a quick thing. So in order to calculate the odds ratio, you want to get the number of people in group A, so holiday abroad, who did indeed get a sunburn, have the disorder, divided by the number of people who did not get a sunburn. So that gives you an odds ratio for the holiday abroad group. And you want to do the same for the staycation group. So this would be 42 divided by 726. And then in order to get an odds, so that gives you the odds in group A, the odds in group B. Now to get a ratio, you're going to divide the two together. So in the way the question was phrased, it was holiday abroad versus staycation. So you're going to do holiday abroad odds ratio divided by staycation. Now I kept the raw values in the math. So you see I put the division above each one. And the reason for that is you do get like sometimes a bit of a difference in your answer. So if you round up, you'll get 44. If you keep all the raw values in and just put it in your calculator, you'll get 46.1. So do bear that in mind if ever you feel like in the MCQ, why am I like a few numbers off? It's okay. Generally, it'll be because you rounded up. It should be okay for the most part, but just bear that in mind. And I think it's safer to just use the raw numbers and like jam that into your calculator. Okay, next question. calculate the relative risk. So I put the totals up for you so you guys don't have to calculate it. And again, because you've worked hard the first time. Has anyone got an idea for me? Oh yes, we have a typer. I love that. The session will go by very quickly if people interact with me. Otherwise, I'll be worried. That's okay, as long as you're honest. I appreciate the honesty a lot. It's all good. Okay, so one of the main things I also want to discuss is the difference between odds ratio and relative risk. So your relative risk, it's a proportion, and odds ratio can be done in most studies, whereas relative risk can only really be done in a cohort study. So that's something to bear in mind. So what we want to do here, again, we have a complete table. We want to essentially take how many individuals have the condition, so a sunburn, over the total number of individuals in that group. And then you want to do the same in the staycation group. So 42 over 768. And then divide the two, and you get 13.3. That means there's generally a 13.3 times increased risk of getting a sunburn. That's the calculation of absolute risk. So odds ratio, you're doing the, I'll just go back to compare for you guys. So odds ratio, you're doing number of people who have a sunburn divided by number of people who don't have a sunburn. Whereas in relative risk, you're doing number of people who have the sunburn divided by total number of individuals. So that's the very subtle difference, but it makes a hell of a difference in terms of the math outcome that you're going to get. So those are the two main, the sense and spec as well, which we'll cover in a second, but those are the two big ones that you want to make sure that you can wrap your head around in terms of interpreting that ABCD table that is notorious for coming up in exams. So try to familiar yourself with these types of calculations. But you guys are doing great. Okay, next. Which of the following would be a confounder in a study seeing the link between ice cream consumption and shark attacks? Smoking, gender, hot temperatures, or age? Hot temperature. Love that. Hot temperature. Okay. Seeing a lot of typing. Hot temperature. Yep. Seems that you guys know what's up. Okay. So does anyone want to have a stab in the dark at explaining what a confounding factor is? And just type it up in the chat. It's okay if not. You have 30 seconds to. No maths are a bit more confident. I love that. Your vibe, Andy, is very appreciated in this. Okay, so a confounding factor essentially is anything that can explain or influence a specific outcome, right? So it may make something seem like it can correlate between each other and is causative, but it's not. So for example, when we have an increase in hot temperature, increase in temperatures, people tend to buy more ice cream and people tend to go into the ocean more. Therefore, both factors, more ice cream, increased risk of shark attacks because the temperatures are hotter, you're in the ocean, and therefore you're more prone to getting attacked by a shark. So another common confounding example is smoking. Many studies have shown that men tend to smoke more, and men tend to also be at higher risk of a heart attack. So a lot of people think, oh, if you're a man, you're more likely to have a heart attack. But actually what they don't think about is if you're a man, you're more likely to smoke, which can also contribute to an increased risk of getting a heart attack. And it's the same thing with alcohol as well. So consuming alcohol is found to increase your chance of mouth cancers, and being a man increases your chance of mouth cancers as well. So alcohol can also be considered to be a confounding variable, which can explain any very odd link or correlation, which doesn't make sense. So that brings me on to my next slide. Here's a little brain break for you. You've done 5 questions, you've done really well. So this is actually to show that the number of people who died by being tangled in their bed sheets correlates at 94% with cheese consumption. So as you can see from the graph, it looks pretty legit, right? Like the lines follow each other. But this again just is another thing to tell us, like, I don't know what the confounder could be between the two, but just generally that a lot of people eat a lot of cheese. I definitely do. And if you get tangled in your bed sheets and you've eaten cheese, it's very easy to say that's the cause, even though logically it doesn't make any sense. Yes, spurious correlations. I love that, Sephora. That's fabulous. Okay, next question. What is the definition of opportunity cost? This is probably the most important thing you need to know with regards to health economics. I don't know whether anyone has a health economic background, but this is something that they absolutely love to discuss, and I think as a doctor, it's something that you really need to think about as well, especially if you plan on like being at a GP, managing your own practice, etc. This is really important to know. Yes, the answer is E. Fabulous. So it is indeed E. So once you have used a resource in one way, you no longer can use it in another way. That's your opportunity cost. For example, if I spend, I have £5, I spend that £5 on a chocolate bar, I can no longer spend that £5 on a burger. So that's your opportunity cost. It's what are you losing? I'm losing a burger by buying a chocolate bar. The other terms that you should just be slightly familiar with, a lot of them are self-explanatory. Efficiency, so getting the most of a limited resource, that's pretty self-explanatory. Equity, the extent to which distribution of resources is fair. Equity is very, very different to equality. Equality is giving everyone the same thing. Equity is meeting the individual's actual needs. So there's no point, for example, for me to give 100,000 vaccines for a COVID booster in every single city in England if some cities are populated at 20,000 and some are populated at 250,000. That is equality, but it's inequity. So it's very important to think about equity. Effectiveness, extent to which an intervention produces the desired outcomes, that's pretty self-explanatory. And utility, the value an individual places on a health state. So utility is how important is it to the individual that they are able to do certain things, or that their pain is taken care of, that their illness is taken care of. For example, a lot of individuals might have a higher, I don't know, some people, for example, an athlete may be less prone to wanting a knee replacement and would want to try to do other methods of getting better. because they don't want to have that limited movement and mobility compared to someone who is a lot more older. So an elderly patient who needs a knee replacement, they just want to walk. So it's really important to consider utility as well of different individuals. These are probably the most important things you should be aware of when it comes to health econ. But again, a lot of them are self-explanatory, and you guys clearly know what opportunity cost is. So why am I even here? You guys got this. You're doing great. Okay, another math question. I'm so sorry, but phase 1 and phase 2 absolutely love their math questions when it comes to public health. So calculate the cost per QALY gained. I will give you guys 2 minutes to figure this one out. Ooh, we have a typer so early on. Oh no, we lost them. How sad. I was very hopeful for a second. Okie dokie. Now I will move on. So this is how you'll calculate the QALY. So a perfect health is measured at 1 QALY. This is your quality of life years. How the quality of health and the quality of their life essentially can be measured. This has a lot of controversy around it. A lot of people say, oh, but how can you measure, put a number on like the value of a year of life? Nonetheless, it's also, again, very common in health economics. It's the best way that we can ascertain whether an intervention is worth it or not. The effectiveness essentially is measured and determined on a QALY. So, as I previously said, so it is expected that the individual will live 17 years having received treatment at a reduced quality of life from 1 to 0.8. And this equals 13.6 QALY. So if they have treatment, they'll live for 17 years with a quality of life of 0.8, 80%, so 20% less than perfect health. Without treatment, they might live only 6 years and for a quality of life of only 0.6. So their quality of life will be reduced by 40%. That gives us the number 3.6. So if we want to know the cost of the total treatment, so 75 pounds is how much it costs per year. And if we know that if we give them treatment, they'll live 17 years. So that means 75 pounds a year. Multiply the two, we get 1,275, 1,275 pounds. Then we find the difference in how many QALYs gained. So without any intervention, they already have 3.6. That's just a given. So by giving them treatment, they gain 10 years, 10 quality of life years. So simple division, 1,275 divided by 10, we get 127.5. So the cost for each quality of life year that this patient gains is 127 pounds and 50 pence. So does anyone have any questions about that one? Was that okay? Does that make sense? I'll take silence as that it's fine. Okay. All right. So another A to D. What is an example of primary prevention? The 5-a-day campaign, AAA screening, watch and wait, and active monitoring for low-grade lymphoma, rehab for alcohol dependence. Huh, very interesting, actually. Okay. I think one more person is typing. I'll just wait. Oh, two people. I'll give it a second. Okay. Yes, Elena, it's actually B. So, what's the difference between primary and primordial prevention? Okay, great question. That's fabulous. So, primordial prevention is, so in this case, is A, promoting the 5-a-day campaign and decreasing sugary sweets. So primordial basically wants to promote good health and get rid of any risk factors in the general population before people come into contact with it. So that usually means you want to try to intervene in specific patterns of behavior and patterns of culture, etc., of individuals before that risk factor has a chance to turn symptomatic. And usually it involves like at a policy level and the wider determinants of health. So the cultural impact of an individual, societal impact of an individual, money, finance, education, all of these things usually involve primordial prevention, which is done at a policy scale. So primary prevention, however, means you're actively working with the individual. So you're screening. So that involves your AAA screening, your pap smears. These are things that help reduce the risk of disease and prevent the disease from causing symptoms. So this includes, like, even during the pandemic, for example, we had at-risk individuals do testing as regularly as possible. So this includes healthcare workers. So healthcare workers were asked to do a PCR test twice a week because they're a risk group for COVID. So that's almost a form of screening as well and primary prevention. So we also have vaccines, which is a form of primary intervention as well. This is all at an individual level. Your primordial prevention is generally at a policy and national general population level. So it's always before the onset of any pathology is your primordial and your primary prevention. Oh, I noticed how my C changed as well. I'm so sorry. My answer for C has changed. So watch and wait low-grade lymphoma, that's generally seen as a secondary prevention thing, which involves slowing the progression of disease in an asymptomatic population. So a lot of individuals will not be symptomatic. So this could be people who may test positive for changes in their cervical cells, for example. People who are in contact with someone else who has COVID and they could be asymptomatic carriers. That's a very common reason why we're in a pandemic. And that involves, again, preventing the progression of disease, preventing it from becoming symptomatic in the individual. So you're more likely certain that they definitely have a condition or are at risk of having a condition. So this generally means we want to detect the disease at the early stages before any symptoms appear. Whereas with tertiary prevention, that includes rehab for alcohol dependence, active treatment against cancers, we want to minimize the consequence of disease. So by this time, the patient is symptomatic, they're very unwell, and we want to make sure we can minimize any impact on their quality of life, make sure that they can retain a good quality of life, reduce any disability, any handicap that they may be at risk of, any impairments, and any consequences. Does that make sense for the difference between primary, primordial, and all of the screening levels, Sephora? Yeah, okay, fab. All right, love that. Love the enthusiasm, love the caps. Okay, next question. What measures the proportion of positive tests who are cases? Sensitivity, positive predictive value, negative predictive value, specificity, or risk? B. Yes, indeed. Fabulous. So the answer is indeed B. Lovely. 3 B's. Great. So one way that helps me think about it is that Sense and Spec generally are concerned with the test, the quality of the test that you're conducting. So sensitivity is your true positive rate. How many individuals who have tested positive are actually positive and have the case? So for example, how many individuals who tested positive for COVID on a PCR actually have COVID and are carriers of the COVID virus? Specificity is the other opposite. So that is the true negative. How many individuals who did not have a positive PCR COVID test did not have COVID and are not carriers? Now PPV, this is where things are a little bit funky, and it takes a little bit of a while, at least for me, to get my head around the difference between all of them. The only way I know the difference is because of the calculations are different. But PPV is the number of positive case tests who are actually cases for COVID, for example. So how many of those positive PCR tests are from individuals that actually have COVID, for example? And the negative predictive value is how many of those negative tests are actually from people who do not have COVID, for example. And NPV and PPV are generally concerned with the patient, and Sense and Spec are generally more concerned with the test quality. Okay, so now we're going to put this into practice. Can you guys calculate the Sense and Spec for an ELISA test? ELISA test is those little drop tests. I don't know whether you guys have seen them before. They're a little bit outdated in a lot of ways. They're an antibody test. So how many, what is the Sense and Spec of these antibody tests with the diagnosis of influenza? I'll give you guys 2 minutes. We're getting some typers. I'm seeing a good consensus in the chat. Love it. Fabulous. You guys have done great. You guys should be so proud of yourselves. Fab. Okay. So as per usual, oh, sorry, this table has gone a little bit funky over here. This is what I get for trying to get a cute template. Okay, so as always, complete the table, get your totals. That's so important. Get all of your totals across and below. Very important. Okay. So to calculate your Sense and Spec, so your sensitivity, we want to take the true positives. So that is how many tested positive and how many actually have influenza. So that's 80. And then we want the number of people who, the total number of people who have the condition. So sensitivity is out of 100 people who had influenza, 80 of them tested positive. So then we ended up with a sensitivity of 80%. On the flip side, how many, the specificity, how many of those people who tested negative were actually negative cases? So that's 95 out of 100, and that's 95% for your specificity. So that's how you would calculate it. So I'll just go over that one more time. So for your sensitivity, it is the number of people who tested positive out of the number of people who have influenza. So that's 80 over 100. So for your specificity, the number of people who tested negative over the total number of people who did not have the condition, which is 100. So then you get 95%. Okie dokie. So that is your answer. So you guys did fab. Well done. Okay. Another fun brain break. So this again just demonstrates how correlation causation doesn't really become a thing. So apparently as temperatures increase, the number of pirates increase as well. And there's a positive trend here, which probably has an R correlation of, this looks like it could be like 90%, which is a pretty high correlation. So that, oh, sorry, the number of pirates decrease, my bad. I guess you can kind of argue that to be true. Less oceans, less pirates can hang about. It's quite interesting to think about. But yeah, again, correlation does not always equal causation. We learned that in GCSE, but it's still going strong. Okay, another question. Calculate the sense and spec here for cancer and no cancer patients. You guys are flying through this. You're over halfway now. Zachary, my man, you are very quick. Very impressive. Sensitivity 44, yeah. Lovely! You guys are great. Okay, as per usual, calculate all your totals, get those values down. And yes, you're correct. So you'll get your sensitivity of 44%, specificity of 95%. Okay, so this is not a very sensitive test, evidently. Fabulous. Okay, you guys are doing splendid. Now, what is meant by lead time bias? If you guys can type that in the chat, that would be fab. Good question. So I think generally it is preferred that you express it as a percentage. That tends to be like the convention. If you do it as just a decimal, that's also completely fine, as long as you obviously don't put a percentage after that. In the case of like MCQs, SAQs, I think as long as you show you're working out and then convert it into a percentage, that's general convention, looks pretty good. And go with the units of how the MCQ answers are sort of demonstrated. But I think generally it's easier when communicating to just communicate it as a percentage. No problem, my pleasure. Perfect, Nidhi, that is a great definition. One of the best definitions I've seen of lead time bias, quite honestly, actually. You've summarized that really nicely. So yes, that is perfect. So it's a really interesting phenomenon. So you have like a formal definition here on the screen, but if you diagnose someone early and you treat them early, then you may think that you've prolonged their survival. But actually, what you've done is just you've been aware of their condition for a longer period of time, for the most part. This isn't always the case, but it's something that does occur a lot with screening programs. So yes, more so, it's the fact that you're aware of this person's condition, or the patient is aware of their condition for a longer period of time. So it appears as if they've survived for a longer period of time. Fab. Okay. Which of the following is false about a case control study? I know that this session ends at 7:30, so I don't want you guys to miss your dinner. So I'm trying to speed it up a little bit. Which of the following is false about a case control study? Okay, got a lot of D's and an E. So the right answer is indeed D. It is not prone to bias and confounding. That is false. Any study you do, no matter how much you try to control everything that goes in and out of this study, you will always be prone to bias and confounding. That's just a given. And in case control studies, the type of biases you're prone to are like selection bias, because you are selecting people based on their outcome. So that's why E would not be false here, because in a case control, it's retrospective. So you're selecting everyone who might have, let's say, misinterpreted the question. No problem, it happens all the time. It happens to me all the time. So if, for example, in case control, you select a cohort of people who have lung cancer, and then you try to see how many of those individuals had an exposure of smoking. So you work backwards. That's the retrospective aspect of it. But the types of biases you might encounter in a case control is like recall bias. Again, people don't remember or can't say whether or not they were in touch with a specific exposure. Misclassification bias. So that one is where you say an individual has the condition when they don't have the condition. So that can happen in more, that generally happens more in psychological conditions, where someone might say someone has a specific type of anxiety or depression, but actually that's not the case. Also in autism, that's a common one where you do get misclassification bias. And a lot of, or like personality disorder, for example. You don't see it very often though, but it can happen. So those, and then general confounders, as we mentioned before, that's just inevitable. You're going to find that in every study that you do. Okay, which of the following is true about cohort studies? A lot of E's. Ooh, a C, very exciting. Okay, this is a little bit, oh, one more person typing before I say anything. I'll just give it a second. Okie dokie, artichoke. So, the right answer is indeed E. Now, the reason why it's not C, this is a trick question. Yes, an outcome measure is risk ratio, but with cohort studies, you can also do odds ratio and incident risk ratio because you're able to get that timing. So with the cohort study, it's longitudinal and prospective, meaning that it goes into the future. You recruit loads of people who maybe had a specific exposure, whatever that may be, and then you just see whether or not they develop the condition or not, whatever that condition could be. Let's think of an example. So you get a group of people that smoke, and you see how many of them end up developing lung cancer. So you are able to determine when they get lung cancer from the time of you recruiting them in the study. And if they're able to recall when they started smoking, you can then work out and see, okay, they started smoking at 15, and then they ended up getting lung cancer at 35. So that's your temporal sequence that you're able to get. So you can measure risk ratio, you can measure incidence. So incidence is very dependent on time. A lot of students do get that wrong in MCQs and SAQs. They don't realize that incidence is different to prevalence because incidence is based on time period, whereas prevalence is only dependent on just like the time at which you collected the data. Cohort studies are not cheap, unfortunately. They are very expensive because they are longitudinal and prospective, so you're actively collecting data. It is good for... Yes, exactly, Zach. That is perfection. So cohort is really good for rare exposures. So you recruit everyone based on the exposure that they've had. An example of a rare exposure could be contamination of like a sewage line or like a water supply, and then you see how many of those individuals end up developing a specific condition. Chernobyl, for example, radioactive exposure, nuclear exposure like that, and then seeing how many of them end up getting cancer as a result of that. So it's really good for rare exposures because you already know all of your individuals have been exposed to that. Case control, as you said, is perfect for rare outcomes because you are looking backwards. So you're just recruiting everyone based on whether or not they have cancer. They all have cancer, then you see what their exposures were and see if you can find a correlation between the two. Perfect, Zach. Fabulous. Great job, guys. So this is a bit of a lengthy question. So a Formula 1 driver wants to know the true mean speed when he's driving around corners. He recorded the speed in miles per hour in a random sample of 100 laps and constructed a 95% confidence interval for the mean speed. The resulting interval was 110 to 120 miles per hour. What is the correct interpretation? I'll give you guys a second. Lovely, well done, Liv and Zach. Yes, fabulous. The answer is indeed C. If there's anything I can tell you, it is please, please, please be confident with confidence intervals. The next few questions are pretty much based around confidence intervals, and I tried to put in every type of confidence interval question that you can get in an MCQ or an SAQ to interpret. I remember from a couple of revision sessions from public health that I had in first and second year, I think, and it was with the infamous Dr. Ron Su. And he basically mentioned that you'll never have to calculate a confidence interval, right? It's way too laborious of a task to do in an exam, in the time crunch and everything like that. You're never going to be asked to calculate one. You have to know how to interpret one. So for this question, what is the correct interpretation? We're 95% confident that the interval captured the true mean speed. A confidence interval will tell you the range of numbers within which you will find the actual mean speed or the true speed that or the true value of a specific study or outcome. That is what a 95% confidence interval tells you, essentially, is that we are 95% sure that this value can lie between, 5 minutes left of scheduled meeting time. Okay, we're nearly there anyway. We're 95% sure that the value we've calculated lies with, that the true value for a specific outcome lies between these two specific values, or this range. Okay, a quick brain, it doesn't cut out. Thank you, Elena. Really appreciate that. Okay, so here's another. Do you guys see how phenomenally perfect this is? So space launches directly correlate with sociology, doctorate awards, and you can just see that it follows the same exact shape and graph. I just found that absolutely insane at how well it seems to be correlated. But obviously we know that there can't really be a link between the two. Okay. What would increasing the confidence interval from 95% to 99% do? Very interesting spread of answers. Yes, so the right correct answer is indeed B. So a lot of people do wonder and ask, like, why do we not just increase the interval to 99% and say that we're 99% sure that the true value lies within these two numbers? And the reason for that is you have to think of your normal distribution curve. So wait, I might just be a nerd and draw it out for you, because this might be helpful. Okay. So you have, oh golly, that did not. Okay. That just, you can kind of see, fine. So if we say 95%, we're saying 95% is here and 95% is here. So we're saying that our true value lies within this range. If we say 99%, we end up increasing that range to here or here. So then what happens is we end up widening the range of values in which the true value could be lying within, and we increase the chance of error because we're saying that, okay, it essentially could be almost any of the values that are within this bell curve, and that reduces the chance of you actually finding the true value, and because you have this wider interval. Does that make sense? I'm not sure whether I explained that correctly or not, or well enough, because essentially we're losing precision. Oh, thank you. I really appreciate that. Thank you, Andrew. The main thing to take from that is that you're not going to get, oh, thanks guys. You guys are so sweet. Okay. It's really kind of you. That's boosted my own confidence a lot. So the wider your interval, then the less precise your answer is going to be. So that's why the answer to this is B, and that's why it's just internationally and universally accepted that 95% confidence interval is probably the most appropriate margin of error to accept. Okay, here's a question. So a sample of 50 students at one school was obtained, and each selected student was given an IQ test. These data was used to construct a 95% confidence interval of said values. Is there evidence that the mean IQ score at this school is different to the known national average of 100? You guys can just say yes or no. No. Good. So yes. So the confidence interval does contain 100. So so there's no evidence to say that this school is performing any differently to the national average. Fab. Great interpretation, guys. Same question. 95% confidence interval for the proportion of 12th grade females who wear their seatbelt was 0.61 to 0.66. Is there evidence that the proportion of females who always wear their seatbelt is different from 0.65? Lovely. Great work, team. That is fab. Yes, there is no evidence. So, because again, it includes that value of 0.65. Great. Okay, now here's two other questions to get you guys thinking, and then we're nearly there at the end. So estimate the p-value of the following odds ratio of 2.3 with a 95% confidence interval of 0.6 to 2.8. And I really want you guys to think about your null hypothesis here. So, okay, so the p-value essentially tells you probability and sort of describes how likely is it that the value is due to chance. Now, conventionally, a p-value that is less than 0.05 suggests that there's a less than 5% chance that probability that this hypothesis was just a chance. It's like a freak accident happened, which is why we can reject the null hypothesis. If a p-value is over 0.05 or over 5%, then we can say, oh God, yeah, it's more likely to be just due to chance. It's not actually a scientific correlation or causation between the two things. That's generally what a p-value refers to. Zach said greater than 0.05. That is fabulous, yes. So I didn't want an exact number, which is where the trick is. I just wanted you guys to get into the mentality of thinking, yes, this would be statistically insignificant. So the p-value of over 0. Oh, that should be 0.05. Sorry, there's missing a 0. So that means the reason why it is insignificant is because your odds ratio crosses 1. Now, a ratio of 1 means that there's no difference between the two groups, for example. So if group A had an odds ratio of 0.5, group B had an odds ratio of 0.5, divide the two, you get 1. That means there's no difference between being exposed to something and not exposed to something. So we cannot reject our null hypothesis because we can't say whether or not the exposure is protective or increases your risk of harm in this case. So it's really important to look at the confidence interval here and see whether or not it crosses 1. Okay. Final question. You have a risk ratio or relative risk of 0.6 of getting sunburn in those who wear sunscreen and those who do not. Can you interpret this for me? This could be like an SAQ question. And they'll expect you to kind of write out what you're thinking here. So if you guys can do that for me, I would greatly appreciate it. Sunscreen is protected from sunburn. Love that. Yeah, pretty much. If you can include some values, that would also be very good as well to increase your chance of marks, just in case. As a little hint. Oops, was that mine? So sorry. Oh my God, why does my inbox say I have 31,000 unread messages? Literally no one emails me. Why does it say this? That's so weird. Okay. Does not include 1, so we can reject the null hypothesis. It's below 1, so statistically significant and negatively true due to being less than 1. Since 1 does not lie within the confidence interval. All very good explanations. All very good explanations. Okay. Yes, so it is statistically significant because our confidence interval does not pass 1. That's very, very true. However, I also wanted you guys to look at the actual risk value being 0.6. So what I wanted you guys to also think about is that the relative risk of getting sunburnt decreased by 40% because it's 0.6. So we had a 0.4 decrease, which rounds up to 40%. In those who wore sunscreen and those who do not. And it is statistically significant, as we saw by the p-value, as well as by the fact that the confidence interval doesn't cross 1. Therefore, we can reject the null hypothesis. So yes, all of your answers are completely valid, but don't forget to actually look at what the value of the risk ratio is or what the value of the OR is and talk about that as well, because that is equally as important as the measurement. Fabulous, you guys did phenomenal. Only 5 minutes.